All right, welcome to the 2020 SCI video project. Today we're going to be talking about the L1 Asia A spinal cord injury. So just a quick refresh on what that means is that Asia A is a complete injury, so we're not going to see any motor or sensory sparing specifically in the lowest sacral levels, so that L4 or S4, S5 levels. And so that's going to directly relate to deep anal pressure and then voluntary anal contraction as well. And so during your Asia examination, you didn't observe that. That's one of the indicators that this is a complete injury. Because L1 is our NLI, we're just going to draw a line here directly onto our spinal cord, just to help kind of visualize that L1 is the last nerve root to go on and innervate something, and the last one we're going to consider. And so what does that mean as far as sensory, but then as far as muscles and functional ability? We're going to talk a little bit more about that. The lumbar plexus advances pretty quickly. By L2 and L3, you're already hitting a lot of muscle groups, but unfortunately those weren't spared in this situation. So as far as musculature goes, L1 is really the lowest level that we're going to see it hit is going to be the psoas major. And even then, to be honest, it's not a lot. Psoas major is typically L1, 2, and 3. So we're getting some. Not a lot, but some. So when you're manual muscle testing that specific motion, hip flexion, you're probably going to see maybe a 3 out of 5, but more than likely you're going to see a 2 or 1 out of 5. So it's still worth investigating and potentially training depending on the orthosis used and the functional mobility of the patient. But that's really the last level down that we're going to see any sort of voluntary contraction. The good news about this is that we have our abdominals intact. We have transverse abdominis intact, rectus abdominis. And then even on the posterior side, and it's helpful to note this, we have quadratus lumborum. This is done by T12, so it should be good to go. And it's going to provide a little bit of lumbar extension, kind of even a counterbalance, in a light way to the psoas major, which is still innervated. But hopefully this is an advantage that we can exploit and something that we can use to progress functional status of our patient. The functional task that we're actually going to talk about today is a sit to stand, and it's going to be performed from a young man in a wheelchair, and he's going to be doing it in parallel bars. And so we have to remember that he has essentially no innervation or voluntary muscle recruitment in the lower extremity. And so what he's going to end up having to do is compensate for this with the upper extremity and really haul himself out of that chair with both arms and create that upward and forward motion that's going to propel him into a standing position. One of the functional expectations for somebody like this is that they be totally independent with bed mobility, with wheelchair mobility, and that they're able to ambulate to some level. And this might be with knee ankle foot orthotics. It could be with hip knee ankle foot orthotics. It's just patient dependent and may even depend on how they progress through different things. So we're going to be looking at that. We're going to assess a quick video and then break it down and go through some other stuff. Okay, so this is the video that we're going to be taking a look at. This young man's going to stand up from the wheelchair directly into parallel bars into a sit-to-stand transfer. But he's not going to be transferring, he's just going to be bearing weight through both lower extremities. And we're going to kind of dissect this a little bit and then take a look about what kind of compensatory strategies we could introduce, and then also kind of go through the actual motion itself. We're going to look at a couple things in preparation that he does, and then a couple things in termination that we're going to kind of pick out. So let's go ahead and watch it start to finish. Great. So first things first, let's actually go back to the very beginning and watch him stand right there. So first thing, typically somebody who isn't able to drive from their lower extremities, we want to see at least a little lumbar extension followed by a pretty quick hip flexion and abdominal contraction forward. What that's doing is building a little bit of momentum. This could also be pathological to the extent where a patient is entirely relying on this. We want a little bit, too much is bad though. So we don't see any though in this case. I think a majority of it is because he's wearing a TLSO. He's probably on spinal precautions due to his injury, which is why we aren't seeing any of that sagittal motion through the trunk. And that makes sense, right? Because he's in a plastic rigid orthosis. Um, that being said, it's also why he has a little issue as we get further up. And so we're going to go ahead and continue it forward with that in mind. And see, he struggles. He struggles. The therapist has to correct the knees for him. Not only is he blocking both knees with the therapist's own knees, but he had to provide a little bit of manual correction there that you saw as well. And so we're just going to kind of go through real slowly from about halfway here as he goes up, up, up. He's not quite able to lock those knees, and it's because his center of gravity is just too far posterior. His hips are still a little bit flexed, his chest is out over his toes, and he's just not able to lock his knees. Because of that, there's no quads to help him with that. His knees are just going to buckle every time. So a couple things to think about in regards to that. His arms are a little bit far forward, and we'll see him adjust and readjust as he finally gets into that comfortable position. Especially his right hand, he has to kind of pull back a little bit. But what you're seeing here, as the therapist places both hands around the iliac crest, almost over to the posterior side, and kind of pulls those hips anteriorly, is we're trying to get the patient to almost assume a more posterior center of gravity. And the reason behind that is we want to therapeutically use those anterior hip capsules, the Y ligaments, if you will. And the idea behind that is essentially to allow the upper extremity or upper trunk's weight to hang out on that. It's going to help us lock the knees. It's going to allow that upright weight-bearing position that we're really desperate to achieve here in a way that is functional for the patient. So we're going to watch it one more time, start to finish. The use of upper extremities here is just really important to understand. He's pulling and pushing almost at the same time, right? Because he has to produce this frontal plane motion and this sagittal plane motion. It's the forward and up. It can't just be one or the other. But you'll see as we kind of go through that it tends to be a little bit too much up and not quite enough forward, which is why we're so posterior displaced with our hips, rather. Uh, the muscles responsible for this, a couple different things, right? He's almost pushing himself up, as we see right here. All right, so that's going to be a lot of triceps. And I would even say, a little bit of pec in there. It's almost like we're doing cable flies. But what we could be doing a little bit differently is engaging more of the lats, more of those posterior chain muscles to provide a little bit of external rotation to the upper extremities, and maybe start swinging and propelling our trunk forward anteriorly just a little bit. Um, and so that's one of the things we're going to discuss a little bit later in how to help rehab this.
So right here, we're going to take a look at that functional activity of a sit-to-stand. And in lieu of parallel bars, we're just going to be using two high mat tables with some extra textbooks, just because I needed the distance for my arms. So we're going to go through the initiation, the execution, and then the termination, and just see what's different. I'm going to play it full speed at first, which it goes pretty quick, and then we'll kind of slow it down after that. So first things first, let's take a look at the initiation. And this is kind of the way that it should have been. This is the full functional potential that we'd like to see. The only thing that this is excluding is the orthotics that would probably benefit a patient like this, just because once you get the knee locked, it stays locked. But within the parallel bars in that video that we just looked at, this is kind of the next evolution of that. So right off the bat, we see that there's already a pretty good lean forward. And maybe this is just because, I don't have an impairment and it's a little bit easier for me to do. Obviously, I don't have a TLSO on. But that, what is that? Probably 30, 40 degrees of kind of a lean forward was a lot of just hip sacrum motion. It wasn't actually too much for my lumbar spine. And what that did is it helped propel me not just up, but forward. It put my upper extremities in a really good position to push up. Let's keep going forward. Forward, forward, forward. And now that we've gone forward, we can go up and allow those hips to fully extend and then kind of lock into a nice little neutral position. And I say neutral in the sense that, they're not hyperextended, but they're certainly not flexed. And we are kind of relying on that Y ligament. It's perhaps a little bit hard to tell just based on my shirt and everything, but I am performing a little bit of a posterior pelvic tilt, again, just to kind of get those anterior ligaments real taut. And that's kind of the goal there, is just to rely on them to help keep you upright. And it is a little tricky to find that center of gravity because you can't be too far posterior, otherwise the knees buckle. We'll keep going here. But as I find it, you can kind of see I even relax there and reposition my hands because my hips are locked due to that posterior pelvic tilt. So I'm even able, I really was making an effort not to use quad strength in this to help simulate kind of the buckling of the knees. And it really did kind of lock out. Once I found the right center of gravity and I was relying on that anterior capsule, I was able to briefly reposition my hands, my arms, and make sure that I was upright. Okay, so let's go ahead and take a look at this first intervention. And there's not a lot of motion to appreciate, so do bear with me. But one of the things I'd be doing with this patient is a couple of posterior pelvic tilts, mainly through activation of some of that anterior musculature that we still have, namely rectus abdominis. Transverse abdominis, I know it doesn't really tilt it as much, but it's still just nice for interthoracic stability. And so I want to start training that specifically without causing too much of a Valsalva maneuver. So cueing the patient verbally to keep breathing through the exercise, not to stop breathing, and that bear down, hold your breath type of thing. But let's go ahead and take a look at how I demonstrate. So it is just that tiny motion there. And you can even see my chest come forward just a little bit as my hips do as well. It's because we're contracting that rectus abdominis and bringing our pelvis into a posterior tilt. So everything's spilling out posteriorly, kind of like the bucket analogy. And I have my hands on my stomach specifically to, I guess, just palpate the musculature. And this is maybe something I'd cue my patient to do, just so that they can feel the activation and realize that there is something going on. Again, because there's not just a lot of, there's not a lot of motion to appreciate. And so what I'm kind of demonstrating here is it's something of a regression. And even though there's a little bit motion still going on with the pelvis, what this really is just a breathing isometric hold. And that's a really good example, that one right there. Breathe in, out, and as you exhale, just really holding it. And that would be kind of the regression to this. Like, let's say they're not able to get any appreciable motion out of a posterior tilt. Well, let's just do some isometric strengthening, work on tightening the core, and then I guess using that as we do our sit-to-stands and as we do the motion, and making sure that it does carry over into functional strength. And so what we're going to see right here is our next kind of functional treatment plan. And this is directly trying to get the patient to be able to lock out while they stand up. And so that's what's really going to make them independent, because as you remember in that video, the therapist has to provide some assistance to get the pelvis forward through the motion, but then once they're up, they're still not forward enough, and so we're having to block the knees and kind of reposition the knees, make sure that they're locked, and even then we're still trying to get them to relax onto those ligaments. And so because we don't have access to the lower extremity strength needed to do all that stuff, we're going to have to compensate with upper extremity strength. And specifically, since we're in parallel bars, we'll be able to kind of pull/push ourselves up into this position that I'm seated in right now in the video. And then with a slight external rotation to the upper extremities, we want to start contracting the lats, kind of depressing the shoulders using lower and mid trapezius, maybe even a little bit of rhomboids in there, and begin to kind of not puff our chest, but punch our chest forward. And that's going to make a huge difference in the grand scheme of things. And so I'm just kind of demonstrating, like, I call them like lat push-ups, just in a seated position. And we are just there, we're using lats to elevate the torso, even if it's, it's not very far, it's maybe an inch or two off of the actual seating there. But it is just to begin working on manual contraction and activation of that musculature. So one of the things that we're going to hit right here, as I kind of mentioned it earlier, we want to be strengthening that posterior chain, working on the ability to retract and depress the scapula. We just did a lot of depression with those lat push-ups. And so this is essentially just, you've done it in the gym, it's a lat row, right? This is a bungee cord, so unfortunately I can't get quite full range out of it, but it's just rowing back, adducting a DD, those shoulder blades together, in an attempt to strengthen rhomboids, mid-trap, and there's some stabilization in there from accessory muscles. Let's take a look. Right, and so what we're going to be doing here is essentially lat pull downs, but it's a modified version of it. And again, this would probably be a pretty decent regression if the patient is unable to perform like a quote unquote lat push-up, right? Because they're having to do their entire body weight. In this, you are still activating your latissimus dorsi, but it's only against the resistance of the band. So, I mean, it's really not more than 8 to 15 pounds, especially with kind of just a light resistance band like this. Let's take a quick look though. And so, again, it's just being able to kind of adduct and depress that scapula. And I maybe could have done a better job at showing the depression of the shoulder there, but again, I'm not quite getting full range, just based on the band that I'm using here. Ideally, we'd want to be bringing that arm all the way down, almost to the same level as like the greater trochanter. Since when we think about where the patient is in the parallel bars, that's where their hands are as they support themselves on them. And so that's the one difference there. Again, it's just working scapular adduction, external rotation of the upper extremities, support there. Again, I want to bring this full circle. We do the upper extremity stuff in order to allow that posterior tilting and everything to begin locking first the hips on that anterior capsule, but then also begin locking the knees and finding that correct center of gravity. And so this is going to assist specifically the termination of that initial video strip that we looked at. The patient has a little trouble repositioning his hands. He's not quite sure where that center of gravity is. And so this is all in an effort to help him have the functional strength to achieve termination of the movement faster, smoother, and hopefully with more efficacy.